Incredibly, septicemia affects 50 million patients every year, and that accounts for 10 to 11 million deaths globally. For all of us, that translates as one family losing a loved one every 2 to 3 seconds.
In this episode, we examine the global burden of sepsis through the COVID-19 lens. We've got some of the top experts from around the world focusing on the practicalities of moving the needle, so to speak, in the fight against sepsis.
We're proud to collaborate with MSD on this educational project. MSD is committed to combating infectious diseases, to tackling antimicrobial resistance, and to coming up with new ways to face this current pandemic.
So wherever you are in the world, we ask that you take a moment to acknowledge the traditional custodians of the land on which you stand.
Welcome to Coda Zero.
So I'd like to now move to Derek. So Derek, I want to discuss the explosion of research that we've had since COVID-19. I went on to PubMed yesterday and put in the search term COVID-19, and it returned more than 37,000 articles. So that's like close to 200 a day if you look at the beginning of the year. And then on clinicaltrials.gov, there's just under 3,000 registered clinical trials. So whilst this is an amazing research response, do you think our research standards have lowered since COVID?
Well, you know my view on this. To some extent, I would say I hope so. And by that, what I mean is a lot of research standards, the word standard is imbued with way too much prestige than it necessarily deserves. I think it's important to remember that when we talk about standards, what we're really just talking about are choices. So, for example, we might choose that we're going to say a standard is that all registration trials should be placebo-controlled. But that is a blanket statement across all conditions. And there are absolutely research questions where the relative gain for a randomized trial of having a placebo is near nil. Sometimes the placebo doesn't even cause blinding. And sometimes blinding just isn't that necessary because there's no practical ability for patients or clinicians to modify the trial, even if they knew the assignment, or modify the outcome. So these sort of, many of the blanket standards that we would have in, say, I would call peacetime, it's totally worthwhile asking oneself when we try to get onto a wartime footing, to be very careful about not hog-tying ourselves with standards that just tie us in knots. Having said that, it's also true that we don't want the wild, wacky West. We have, I didn't know how many papers have been published, but I do know how many papers we've got at JAMA. We've had 15,000 papers this year.
Our timers stopped working. We can't tell.
Wow. That is huge.
And so it's monumental just trying to read them all. One wonders if it's hard for us to just keep up with reading them, then you do ask the question, did people cut corners in different places? So I think in general, I would say everyone is feeling pressure to move quickly. Many regulatory authorities are feeling pressure to lower standards, etc. And I would say we should consider lowering standards, but I'd like to be intelligent about which standards we lower. And I wouldn't frame it pejoratively. Some of the choices we make to engage in, for example, a more pragmatic design might be the perfect decision for the moment.
Thanks, Derek. I actually wanted to ask Simon just on this. So do you think there's parallels with trying to find the magic bullet for sepsis as there is for COVID?
Yeah, well, as I mentioned before, there's some suggestion of people making the kind of mistakes that that we've made with sepsis over many years in terms of measure something, it's abnormal, it must be causative, rather than being an epiphenomenon or being part of the issue. Years ago, Derek and Flavia and I have been involved in the International Sepsis Forum for some time, and years ago there was a meeting in Amsterdam. I think Derek was a co-chair with Tom van der Poel, and it was a fantastic meeting. A lot of people came from the basic science world, and being a clinical researcher, my striking that people would get up and they would talk about their compound or their receptor and their knockout mice model and how it improved sepsis outcome if you interfered with this particular molecule, but it doesn't translate through into clinical practice, I think, because it's a complex issue that we're dealing with. So yeah, it's a little bit worrying. I mean, I think there's been an enormous, there's a lot of good stuff. I mean, you know, if you look at the recovery trial in the UK, you know, recruit 1,000 patients in the first week of a trial. I mean, this is an extraordinary event, regardless of what you might think about some of the ways some of the things are done. But we should be learning a lot from this and being able to look at this and say, okay, this is what happens when a government gets behind a research process. And I get asked, you know, all the time, and I'm sure everyone does, who's your non-medical friends say they want to know, first of all, they wanted to know if there'd be a ventilator available for them if they got COVID, not realizing that would be a really bad thing. Hey, Simon, you'll make sure I get a ventilator, won't you? That would be a really bad thing. Then they want to know whether there's going to be a vaccine available. But everybody's heard of COVID. Everybody knows what's going on. So I think there are big positives there that we see, that what happens when someone gets behind the governments get behind a research program, funders, you know, it's disrupting other research though, you have to say this. I mean, you know, in the UK ICUs, they were told they were only allowed to do COVID research. So if you're running some research trial that you've been working on for 5 years to answer a really important question, suddenly, well, you can't do that anymore. So positives and negatives, and I'm not sure what's happening in other parts. In Australia, we didn't have it wasn't mandated, we stopped doing it, but we did stop doing research because the cognitive load on our clinical staff of learning all these new protocols, of learning how to, you know, new intubation protocols, new PPE protocols, how are we going to cope with all this extra work, etc. That was just too much to put other stuff on top of them. So there are all these adverse effects. I think I'm a kind of Shut up.
I need to stop you because I didn't realise he was going to hog all your time, Derek.
Derek doesn't like talking in public.
So I want to go back to Derek, but thank you, Simon. So
I was responding to something Simon said.
Yeah, go for it.
Am I with you or not? So Simon, this is twice now he's talked about the cytokine storm and how he doesn't think that's a very good model. I actually want to say that COVID-19 has definitely been an example of helping us see the enemy, and it is us. In many ways, it has just been us holding a microscope up to ourselves. And one of the things that I've definitely seen, just as these thousands of papers have come across my desk and the desk of the other editors at JAMA, is everyone's an expert. Everyone has a theory for COVID-19, and nearly all the time, that theory, by some magical chance, happens to be that they can apply what they know from their disease. And hardly anyone wants to stretch outside their lanes. We have really been shown up to be incredibly narrow-minded. We're so super specialized that everyone is seeing COVID-19 through their own pair of glasses. And it's a big problem for the entire scientific community. Infectious disease public health experts will say things like close schools because they know about the infectious disease, but they know nothing about the consequences of closing schools. Sepsis researchers say, what on earth are you giving this monoclonal antibody for? There's no cytokine storm. But meanwhile, the person saying it is a rheumatologist or an oncologist who knows far more about some of the, for example, ACE2 manipulation than we might know. And it's been, frankly, a bit sad to watch how little we really listen to each other. On a large scale, COVID-19 has really shown up that many of us have become so super specialized. It's very, very hard for us to think across different domains or think with any range.
So what's the solution to that?
Editorializing. I mean, the solution starts by listening. And I totally think people, they're in such a rush. It's hard for them to even hear that someone else has something to say. And I totally think that some of the research, the thousands of trials that are being logged on clinicaltrials.gov would be much nicer if there were far fewer trials, but that the research groups were all much more multidisciplinary research groups that all got together and merged their ideas and learned from each other. It's exhausting to see so many small individual efforts being proposed by people with such confidence that they know the answer, that they almost don't want to listen to anyone else.
And I think this might lead quite nicely into the JAMA editorial that you wrote around learning while doing. So perhaps you would like to talk a bit about that.
Sure. Learning while doing is, so for me, a lot of the problem here is that we're trying to do two things simultaneously. We're trying to care for patients as well as possible, and we're trying to learn as fast as possible. Now, it turns out, when you think about it, that's actually what goes on in many endeavors of life. Again, to continue the wartime analogy, when Churchill was trying to work out what to do when he came into power, he realized he was having to fight battles right there. And he also knew that the way in which he was fighting battles meant he was going to lose the war. So while simultaneously not losing the war, he had to learn how to fight the war better. And so it was not enough to say, I will fight this battle the way I did yesterday, or to say, I don't fight battles, I just invent how to fight new battles in the future. He had to do both. So here we have, 20 million cases of COVID-19, and we've randomized maybe 20,000 patients. That means that we are studying in a trial 1 in 1,000 patients. So let's just step back and imagine we were one large medical brain, one doctor taking care of every patient with COVID-19 on the planet. And we know when we see the first patient, we have no clue what this disease is. Would we really think that for every 1,000 patients, we would treat 999 exactly the way we used to know, which was nothing, because we've never managed it before, and only try to learn from 1 in 1,000? That is ridiculous. That level of knowledge accrual means we will be here for centuries before we solve this problem. We would never think of it that way. We would totally want to be learning from every patient in front of us. So why are we not doing it? We're not doing it in part because we've divided the world of medicine into people that take care of patients and people that try to learn how to take care of them in the future, which is crazy. Everyone should own both jobs. Since we're not going to instantly turn every clinician into a researcher and every researcher into a clinician, what we need to do right now is have the entire research community really think about research that isn't impossible for clinicians. They should totally think about rolling out study designs that you can do while taking care of the patient. And then similarly, then we should think, when we're taking care of patients, how can we find research programs that we can meld with at the time? And otherwise, we're going to continue to study one patient in 1,000. That's mind-numbingly awful. So, I think that's why I think, for example, it is ridiculous, faced with a pandemic to which we do not know the answers, to stick to research designs that are going to take years to enroll a few hundred patients. It is collective madness.
So isn't the recovery trial the learning while doing design?
Yeah, so I think recovery trial is a big yes and a little no. The little no is, so recovery is brilliant for running in Britain. There happened to be lots of patients in Britain. The trial design for recovery would have been sitting there looking perfectly nice on paper if Britain was having as many cases as Australia, but there'd be hardly any people enrolled. And so one of the first things to think about is, how could recovery have actually functioned as a global trial? How could it have overcome funding from different agencies, collaboration across different countries, and so forth? And then the other thing is, could the design have also worked a little bit harder to keep learning as it goes? Could it have used a randomization design where hardly anyone is in the control arm because no one wants to be the guinea pig that gets placebo? So that's the small no, that there are a few things that they could have done to have leaned in even more towards clinical care and even more enrollment. But I would say a huge yes to recovery for the thing that Simon was talking about, just setting as a goal. We should be trying to learn from every patient and trying to get every patient in the hospital in the trial. That's totally what we should be doing. And because of that, the researchers wanted a design that was easy for clinicians to participate in without them thinking, wait a minute, there's no time to do this. I have to go ahead and take care of this patient.
Yeah. So a question from the audience was, how do you get the balance right in respects to getting results out early versus, accurate publications?
Okay. I thought you were going to talk about the balance of learning while doing.
No, we've moved on.
Sorry.
I've got to get the audience in.
Yeah. That's a great question. And it's something we're discussing all the time. So, for example, at JAMA, we are not telling authors to not post something on preprint if they don't want to. If they say, oh, if we bring it to JAMA, does that mean that we cannot put it up on preprint? We're sort of saying, if you want to put it on a preprint server, you can. I think everyone has seen what's happened with the preprint servers. Certain things have gone up there and they've been incredibly helpful, like the recovery trials. On the other hand, the Mediterranean hydroxychloroquine trial got posted on a preprint server and probably put the world into a tizzy. I totally believe that information wants to be free. We're just clumsy right now. So my view would be, I would keep pushing out more data and more information. And then along the way, it'll be a little bit ugly as we learn that we're not sensible about applying filters. But then there'll be human ingenuity. There'll be smarter ways of then filtering and curating the information. This is just the latest step in a centuries-old process of making information flow more quickly. And every single time there's a big change, whether it's the telegraph or the printing press or whatever, there's all these aesthete academics who think the world will be ruined when suddenly all books can be printed on a printing press, or when suddenly you can talk to someone on the other side of the country via a telegraph. And every single time, maybe the world is ruined, but every single time we do it, after the initial burst of this information explosion, we get more efficient in how to curate it. So I think the balance is push the information out and then stimulate the community to think about strategies to help readers curate and distill the information better. And it totally puts pressure on journals to think about speeding up peer review. I think it makes us all uncomfortable, and it's incredibly healthy.
Excellent. Thank you, Derek.